Welcome to the Talking Ketamine podcast, the show where we explore the science behind this fascinating molecule. This is episode 44, Ketamine and Sickle Cell Disease.
Thanks for joining us. Today we're looking at a massive study from 44 children's hospitals that asks a critical question. Can ketamine help kids suffering from the excruciating pain of sickle cell disease?
That's right, and we're going to get into a really detailed analysis of a huge multicenter study. We're talking over 74,000 hospital admissions.
It's a staggering amount of data.
It really is. And our goal here is to understand how ketamine is being used for kids and teenagers hospitalized with sickle cell disease, or SCD, from around 2016 all the way up to 2023.
Right, and specifically how it's being adopted or not as a tool to reduce opioid use.
Exactly. And crucially, we're going to look at this really surprising connection the researchers found between when the ketamine was given and how the patients did. Things like, how long they had to stay in the hospital.
To really get why this study is so important, you have to first understand just how serious this situation is. Sickle cell disease, it's an inherited blood disorder.
And it affects a lot of people.
Over 100,000 in the U.S. alone. And for them, these acute pain crises are just devastating. They are the #1 reason for hospitalization. We're talking more than 3/4 of all inpatient stays for this population.
So what's actually happening in the body to cause that level of pain? Why is it so intense?
It all comes down to something called a vaso-occlusive crisis.
Okay, that sounds pretty technical.
It does, but it's simple when you break it down. Vaso means blood vessel and occlusion is a blockage. The blood cells in these patients aren't round and smooth. They're shaped like sickles or crescent moons.
Rigid and sticky.
Exactly. And they get stuck in the small blood vessels, creating a dam. Blood flow gets blocked, tissue doesn't get oxygen, and that causes just agonizing pain.
And for so long, the go-to response has been opioids, powerful painkillers.
Right. They are still the first-line treatment. But the problem is, children frequently say their pain isn't well controlled, even on high doses. And then you get into the whole issue of long-term opioid use.
Which we know is full of risks.
Full of them. You have the short-term side effects everyone knows, constipation, nausea, drowsiness.
Yeah.
But the long-term risks, that's where things get really dangerous. You get tolerance, of course.
Meaning you need more and more of the drug to get the same effect.
And then you have this other more sinister issue called opioid-induced hyperalgesia.
Okay, that's another one to break down. Hyperalgesia.
It means increased sensitivity to pain. So the very medication you're taking to reduce your pain, actually, over time, rewires your nervous system to make you more sensitive to pain.
That's just a terrible paradox.
It's a horrific cycle. The pain gets worse, so you need higher doses, which in turn can make your baseline pain even worse. It's a trap.
And this is exactly where ketamine comes in, because it works on a totally different system. It offers a way to break that cycle.
Precisely. It's what we call an opioid-sparing adjunct. It helps with the pain, but doesn't rely on those same opioid pathways. Its main job is as an N-methyl-D aspartate, or NMDA receptor antagonist.
The NMDA receptor.
Right. Think of the NMDA receptor as a volume dial for pain signals in your brain and spinal cord. With chronic, intense pain, like in a sickle cell crisis, that dial gets cranked up to 11 and gets stuck there. It's a process called central sensitization.
So the nervous system itself starts amplifying the pain.
Yes, exactly. Ketamine comes in, and by blocking that receptor, it basically forces that volume dial back down. It turns off the amplifier.
And that does more than just lower the pain in the moment.
Much more. It also helps block the development of opioid tolerance and, crucially, reduces that hyperalgesia we were just talking about.
And this isn't just a theory anymore. Major medical bodies are recognizing this.
They are. The American Society of Hematology, or ASH, put out a conditional recommendation back in 2020. They recommended using low-dose, what we call sub-anesthetic, ketamine infusions for both adults and children hospitalized with these crises when opioids just aren't cutting it.
So that 2020 guideline is a key milestone, and this huge study gives us a real-world look at what happened next. How did hospitals actually respond?
That's the core question here. Again, we're looking at over 74,000 admissions across 44 children's hospitals, a massive data set.
So after the guidelines came out, did everyone just start using ketamine? What did the numbers show?
Well, you might be surprised. The overall use was actually pretty low, just 4.5% across all those admissions.
4.5%, that seems really low.
It is, but there's a definite trend. Back in 2016, it was only used in about 2.3% of cases. By 2023, that had climbed to 5.7%.
So it more than doubled. It's a slow rise, but it's a clear one, and it tracks right along with those ASH guidelines being published.
Right. It seems the message is getting out just slowly.
So who are the patients that are getting it? Is it being used for everyone?
No, not at all. It seems to be reserved for the more complex and severe cases. For instance, kids aged 12 and older were at least twice as likely to get it as younger children.
Okay, so they're waiting until the patients are older, maybe have a longer history with these pain crises.
That seems to be the pattern, and it's backed up by the other medications these kids were on. The patients who got ketamine were much more likely to also be on drugs for chronic pain management, like a gabapentinoid or methadone.
And they were also more likely to be on a drug called hydroxyurea. Tell us why that's a significant marker.
Hydroxyurea is a standard treatment for SCD. Its job is to reduce how often these crises happen. So if a patient is on it, it's a signal that they have a pretty high disease burden.
So seeing ketamine used alongside these other drugs basically confirms that clinicians are pulling it out of the toolkit for the toughest cases, the ones where the standard approach just isn't working anymore.
That's a perfect way to put it.
Okay, let's get to what I think is the most stunning finding in this whole analysis. The researchers didn't just look at if ketamine was used, but when.
Yes, this was a really crucial part of their analysis. They split the patients into two groups. Early administration, meaning ketamine was started within the first 3 days of the hospital stay.
And late administration.
That was day 4 or later. And the difference in outcomes was, well, it was night and day.
So let's hear the numbers. The early group, how long was their hospital stay?
The median length of stay for the early ketamine group was 6 days.
6 days, okay. And the late group?
The median length of stay for the late ketamine group was 12 days.
12. So 6 versus 12. That's cutting the hospital stay in half.
It's an enormous difference. And it wasn't just length of stay. The use of IV opioids mirrored that finding perfectly. The early group needed IV opioids for a median of 4 days. The late group, 9 days.
Wow. But hang on. Could it be that the sicker patients just ended up getting it later as a last resort, and that's why they were in the hospital longer?
That is the obvious question.
Hmm.
And it's what makes this finding so powerful. It was actually the opposite.
Really?
Yes, the data showed that the patients who got ketamine early often had signs of being sicker to begin with. They had more prior hospitalizations, and they were more likely to be admitted directly to the ICU.
So even though there were the more severe cases on paper,
You still get out of the hospital in half the time and needed far fewer days of IV opioids.
that strongly suggests that getting in there early with ketamine before that pain amplification system really kicks into high gear is the key.
It points directly to that conclusion. Interrupting that central sensitization cycle early seems to make all the difference.
Which brings us to the big, difficult question. If the data is this compelling for early use, why is the overall adoption rate still under 6%? And maybe more importantly, why is it so different from one hospital to another?
That variation is the reality check here. It's massive. In 2022, you had some hospitals in the study that used ketamine in 0% of their SCD admissions, and others were using it in up to 20% of cases. That's a huge gap in care.
So what's holding it back? What are the barriers?
Well, one of them, unfortunately, is still stigma. You say ketamine, and some people, providers and families alike, still think of it as a recreational drug, not a legitimate, powerful analgesic.
And what about the systems themselves, the hospital policies?
That's probably the biggest piece of the puzzle. Remember those ASH guidelines? They say you need appropriate expertise to administer it.
Which sounds reasonable, but I sense a but coming.
But it means hospitals create really strict rules. Often, a regular hematologist can't just order a ketamine trip. They might have to get a formal consult from the pain medicine service, which takes time, adds layers of bureaucracy, and slows everything down.
So the SCD doctors who know the patient best might feel like their hands are tied.
That's what the data suggests. SCD clinicians report being less comfortable prescribing it on the hospital floor compared to, say, an ER doctor, mainly because of these institutional hoops they have to jump through.
So the problem isn't necessarily a lack of belief in the drug, but the logistical hurdles to actually using it quickly and effectively.
It seems to be a major factor.
So to pull this all together, what we're seeing is that ketamine use for kids with SCD is, it's on the rise, but it's slow. And it's mostly for older kids with more complicated cases.
That's right.
But the real insight here, the most powerful takeaway, has to be about timing. The evidence strongly suggests that when you use ketamine early in a hospitalization, you see a dramatic drop in how long a child is in the hospital and how many days they need powerful IV opioids.
It seems the faster it's used, the better it works. It's a preventative measure as much as it is a treatment for the immediate pain.
And that signal from the real world really provides a clear mandate for researchers. We need trials to prove this association is truly cause and effect.
Absolutely. But it also leaves us and you with a really challenging question for our healthcare systems. If a simple change in timing could potentially cut a child's suffering and their hospital stay in half, what is our responsibility to fix the institutional barriers, the stigma, the red tape that lead to this massive variation in care we're seeing across the country?
A very important question to think about. Thank you
Right.
for walking through this critical analysis with us.